Dystonia is a movement disorder characterized by sustained or intermittent muscle contractions that cause abnormal and often repetitive movements. Dystonia is classified as primary when it is the most important feature of an idiopathic disorder, while secondary dystonias are symptomatic disorders arising from another underlying disease. Biofeedback is a technique that consists in providing the subject with increased information of a physiological process, allowing him or her to increase awareness of the process itself and to acquire voluntary control over it. The objective of the present thesis work is to test the effectiveness of an EMG-based vibro-tactile biofeedback in children affected by primary and secondary dystonia, and to compare this effect with the influence on healthy subjects. The working hypothesis is that a positive effect should be recorded only for the secondary population. In the case of subjects affected by primary dystonia and healthy subjects, the use of a biofeedback strategy should have no clear role in improving performance. At least, the behavior of the tested primaries should be consistent with the behavior of the healthy participants. The protocol consists of 2 weeks of data collection, in which the subject is asked to perform the so-called spoon task, which simulates the act of self-feeding. The analysis of the motor exercise was performed through the evaluation of the EMG activity of 8 muscles of the upper limb tested and the kinematics of the shoulder joint, the elbow joint, the wrist joint, and the spoon. Some indices were computed: temporal indices, kinematic descriptors of the final output and of the movements of the entire kinematic chain, and indices related to the EMG activity of 3 couples of antagonist-agonist muscles. 15 patients were recruited, 9 primary dystonic subjects and 6 secondary dystonic subjects. A group of 12 age-matched healthy subjects were also recruited. For what concerns time and speed of execution, the practice with the BF device prepossessed the behavior of the primary subject and the secondary subjects almost in the same way. Even looking at the smoothness of the movement, there's no evidence to confirm that the exercise performed with the BF produced better results on the secondary group. For what concerns the elbow range of motion and displacements of the shoulder, it's likely these 2 parameters do not identify so well the behavior of the subjects, who adopted different strategies that translated into a great intersample variability in the movements of the entire kinematic chain. Finally, looking at the EMG parameters, there's no clear tendency in the favor of the initial hypothesis. Indeed, better improvement was evident when the BF device was used for both the primary subjects and the secondary subjects. In general, better improvement with the device was recorded for both the primary subjects and the secondary subjects. Even for the healthy subjects, the device accelerated learning processes. Hence, these results do not allow us to support the hypothesis the thesis is based on. Even individuals affected by secondary dystonia seem not to be so much favored by using such a strategy. On the other hand, for the subjects affected by primary dystonia and for the healthy subjects, the use of a biofeedback strategy seems to have a role in improving performance.